size increase. One is the chordate width to the ratio with the right lobe width, and this is pretty specific. Now, nodularity, it is very important for the sonologist, the radiologist, to see the surface of the liver. It's easy to see it as in this image when the patient has ascites, but when the patient does not have ascites, it is not usually commented well upon. And those are the patients who you suspect of portal cirrhosis, and you want that information from. So surface nodularity is very specific and very sensitive as well. The liver echo texture is important. It is again a subjective opinion. Unless it is very highly coarse in echo texture, you'll get different reports from different sonologists for the same patients in the same period of time. But liver which has multiple nodules, which may be regenerating nodules and dysplastic nodules, though that's a sign of obviously a long-standing cirrhosis. So other signs, telltale signs of portal hypertension you have to look for are ascites, splenomegaly, varices, and the last point of reversed portal flow. Now, when you order an ultrasound for cirrhosis, this is a point which we as radiologists usually do not look into. We don't see the portal flow. So if you are not getting that information, I think you should ask for it from your radiologist once you get the report. Doppler of the portal vein, flow reversal, the collaterals, the prominent hepatic arteries with increased flow is another sign, and hepatic veins which are thin, and there is loss of physicity in them. So all these are technical points, and you should know them as physicians, because you should expect that information in a report. So liver, again I'll repeat the points: liver surface irregularity, echo texture nodularity, the size of the liver, the volume redistribution, is there ascites, portal vein diameter, the direction of the blood flow in portal vein, is there splenomegaly, what are there varices present, and obviously is there any mass, which we'll touch upon in the next part. So what happens on the ground is, as mentioned before, that the reliability of ultrasound reports in general is pretty questionable. There are few people who do it the right way, few people who have the right equipment, and there is a communication gap between the ordering physicians and the radiologists. What are the solutions that we should be looking into, because ultrasound is an extremely important modality for surveillance, and there is a huge gap between in this field. So more frequent interactions and feedback. When you get a wrong report, you should be writing the question that hasn't been answered, and that should go back to the radiologist, so at least he gets the feedback. You should demand, encourage and assist in development of disease-specific templates for reports. So you can get, for example, in all cirrhotic, potentially cirrhotic patients, there should be a heading in the report about the direction of the portal flow. And apart from that, other stuff as well, as I've mentioned before. You should publish that data, and obviously MDTs should be done with the radiologist, so the feedback is there. And this is just a simple point-wise slide in which you can see the different things that should be mentioned, preferably be mentioned in headings, so you get an overview of the patient's condition, the liver and the cirrhosis. Now we come to HCC and cirrhosis. Now in Pakistan, obviously the data is not that much available, and the condition and the situation is also not that good, as is in the rest of the world for surveillance in ultrasound. Surveillance is crucial. A randomized controlled trial indicated that biennial screening reduced HCC mortality by 37%. This is from the ASLD. And 3-year survival nearly doubles if patients follow a strict surveillance program. There are obviously many different surveillance regimes, and usually the ones being followed are an ultrasound with alpha-beta protein every 6 months in high-risk patients. So what is the state of HCC surveillance according to different studies in Pakistan? Unfortunately, 8 out of 10 patients are diagnosed when they become symptomatic. That means that they were not under surveillance, and when they become symptomatic, that's when they're diagnosed. And 2 out of 10 are detected either incidentally or when they're under surveillance. So it's less than 20% that are detected when they are under surveillance. And as low as 10% patients in Pakistan with risk factors of HCC undergo regular screening for various reasons. So again, let's talk about what are the ground realities. Are all cirrhotic or patients, or are all patients at high risk registered in a regular screening program? What is the patient compliance? What are the causes of the patient being non-compliant? One of the main causes obviously is lack of knowledge about the potential disease which they can face in the near future. And ultrasound detection rate of early HCC is obviously not that good in the world, and especially here in Pakistan, because of lack of dedication, lack of training, as mentioned already, lack of expertise and proper equipment. What are the solutions that might help in this regard? Informing and educating patients about HCC and importance of regular screening is extremely important, and one has to invest time, energy, if not finances, in this point. Establish a local and regional registry for patients who are on high risk. Interaction with and feedback to the radiologist that you're sending your patients to. And involving the pharmaceutical industry or other stakeholders to help develop a system to follow up patients who are on a screening program. Now, in this age of technology, one can easily come up with solutions, novel solutions, in which you can offer a screening program to the patients, and then obviously publish your data that you've come up with. I think it's stuck here. And it's important that how do you know that your radiologist that you're referring to is actually getting better? You know when he is getting better when you start getting early HCCs being reported from your radiologist. Now we go on to CT. When do you do a dynamic CT? For diagnosis, number one is for the diagnosis of HCC. When you do find a lesion in the liver, go ahead and order a dynamic CT. As a screening study prior to liver transplant, follow-up for portal vein thrombosis under treatment, and planning CT before TIPS. There are other indications as well. But I'll show you a few images of CT in cirrhosis. There is obviously a surface irregularity and nodularity, and that is visible in the shrunken liver. Varices are important findings in cirrhosis. These are massive paraesophageal varices, and there is on the image on the right shows the patent umbilical vein. Now varices are detectable under ultrasound, especially the patent umbilical vein, and that should be looked for. One can see renal shunts. Patients with renal shunts have less chances of getting ascites and more chances of getting portal vein thrombosis. This is thrombosed portal vein, partially recanalized. There can be cavernous transformation when you don't see a portal vein at all, and there is a bunch of vessels in the porta hepatis, and these represent collateral which are draining the region. Now, CT for diagnosis of HCC, and this was when I was working at a good tertiary level institution, there was no question about it. But when I moved out of that hospital, I had a very hard time in convincing referring physicians that we do not have to do a biopsy to prove HCC for a certain group of patients. So in a study in Pakistan, it was noted that only 1.7% patients are diagnosed on CT findings alone, while various combinations of CT, alpha-beta protein biopsies are used in 62.5% of patients, and these are patients which would be who do not need probably biopsy. I think this was an old study, it's probably getting better. So a typical HCC would be hypervascular, and it shows enhancement in the arterial phase, which is the image on the left, and you can see the lesion getting darker, which means that the contrast has moved out, and this is called washout in the porthovenous and the delayed phases. A cirrhotic patient with this finding and with no other mass in the rest of the abdomen, that is, you don't need any other test for confirmation of diagnosis. So when do we do a biopsy? When the patient does not have cirrhosis, he does not have hepatitis B or C. It is atypical enhancement pattern on CT and MR, or when the radiologist tells you that there is potentially another lesion which might be the primary, maybe a liver lesion or pancreatic lesion. So any patient with a lesion picked up on ultrasound, any patient, be it cirrhotic or non-cirrhotic, should have CT liver dynamic as against having a CT abdomen. This is an important point because patients get a normal CT abdomen, and the radiologist then asks for requests as CT, triphasic CT, and there is again that confusion there. When there is high clinical suspicion of malignancy despite a normal ultrasound report, high alpha-beta protein or a significant recent weight loss, and when you're suspecting lesion malignancy, then you go ahead and do this CT scan. So a simple algorithm, and I'll hurriedly go through it. When there's no lesion on ultrasound but raised AFP or a lesion on ultrasound, you go ahead and do CT. If there is HCC, you refer the patient to a dedicated facility where there are treatments available. If there's no HCC and you still have high suspicion, you go ahead and do an MR. If there is no HCC in that MR, you put him back to the screening program. If there is an HCC, you again refer the patient to a dedicated center. So practical problems, patients get substandard CT scans because CT scans are, everybody has put CT scans here and there, and the quality is not that good in quite a few. There's lack of knowledge about diagnosis of HCC, substandard reports are there, and there are no MDT settings in many centers. So what are the solutions? You refer the patients to reputable diagnostic centers or hospitals where imaging is supervised, where you know the imaging is supervised by senior radiologists. You invest time in developing MDT meetings, you give feedback to the radiologist, and you educate the patient about where to get the CT. Usually what I do is I don't tell them to get a CT from this particular center or that. I give them a whole list of all the good centers and he has to choose. So I think that is important, that the patients don't go for cheaper substandard studies. MRI is for patients with multiple regenerating dysplastic nodules in which CT is inconclusive. When you still suspect, when you have to rule out an HCC in a usually nodular liver, I'll be showing you one in the next slide, to assess vascular invasion of HCC, again in which CT was inconclusive because that has implications for treatment. To rule out HCC where there's a high suspicion with no detectable HCC on CT, even then you may find a small HCC lying here and there. And this is again the arterial phase on the left and the delayed phase on the right, where the arrow points to the HCC, which is enhancing in the arterial phase and gets washout in the delayed. This image is a CT scan in which you can see the liver studded with nodules, but if this would be inconclusive, then you go ahead and do, and you suspect an HCC, you go ahead and do an MR, and that is more specific and more sensitive for detecting small HCCs. Elastography is the clinical indications of elastography are fibrosis, staging for chronic liver disease, follow-up of patients with who are cirrhotics, evaluation of patients with unexplained portal hypertension, and response to treatment. So the take-home message is that we have different societies working in the country, and we talk about different things, and inter-society collaborations, meetings, workshops, that's an important thing that I think we should be doing. We should establish registries, and that again can be done with collaborations. Start MDT meetings as per international standards and help other institutes to start these in the proper way. Invest energy and time in patient education, and obviously do research and publications. Thank you.
Thank you very much, Dr. Assam Kiani, to highlighting the real critical points which we face as a physician. Now I request next speaker, the gastroenterologist from Apasl, Dr. Habib Jadoon. He is going to present non-invasive serological markers of fibrosis in chronic hepatitis.
Organizing committee for this opportunity. To begin my talk, I'll start with a case. A 61-year-old man comes to your clinic. That means probably a junior colleague over here, or a physician, or a general practitioner, or a physician. And he comes with the following investigations: with a hemoglobin of 14, WBC of 12,000, platelet count of 100,000, bilirubin of 2.2, ALT 80, ALP 300, and he's HCV positive, and he wants to know how bad his liver is. That means, does he have cirrhosis, or is he in the initial stage of the disease? You presume that you are in Pakistan and in a peripheral or primary care setting, and in order to get some information, what is the next step you're going to choose? Are you going to request AST, request ELF score, or request a fibro test, send him to a tertiary care hospital for a fibroscan, presuming that liver biopsy is not an option over here? So just keep your answer in your mind, and we'll go through it. You request AST, which is available in your local lab. It's a simple basic chemistry test, and the answer comes to 120 international units. You've got some information of some scoring systems, and one of them in your mind is APRI, and you somehow get the calculation done through this equation, and you get a value of 3. How will you interpret this value of 3? You keep this in your mind, and we'll talk about it later on. So we come to, why is there need for evaluation of fibrosis to begin with? All liver insults will lead to acute, from chronic liver disease to cirrhosis, to decompensation, hepatocellular carcinoma, and ultimately death. And this all depends on the progression of cirrhosis or fibrosis, and its consequences like portal hypertension. So assessment of fibrosis is important because it helps you in management of individual patients. You can stratify them according to various algorithms, for example, in the treatment of hepatitis B, C, and NASH, and also in other chronic liver disease like autoimmune. And if you detect cirrhosis on screening, you can do further screening for HCC and look up for esophageal varices. You can use fibrosis staging for evaluation of treatments, antiviral and now antifibrotic medications, and you can use them for screening purposes of at high risk patients. We just briefly go through the mechanism of fibrosis. Whatever insult commonly B or C, NASH and alcohol will lead to inflammation, and that will the major proponent is the hepatic stellate cell. This is a quiescent phase, and this is activated, and it transforms into myofibroblast and leads to synthesis of collagen, elastin, and glycoproteins and proteoglycans, and this leads to fibrosis and cirrhosis. On the top, you've got markers of liver cell injury, markers of inflammation, markers of fibrogenesis, and biomarkers of fibrosis and extracellular matrix deposition or turnover. So this is what happens in fibrosis. This is a normal liver space of disease, a normal hepatic stellate cell in the quiescent phase, normal Kupffer cell, and this is extracellular matrix deposition in this area. And these are the activated or the transformed hepatic stellate cells and the activated Kupffer cells. The normal extracellular matrix is composed of fibronectin, collagen 4, 6, perlecan, and when it is transformed, you get a new basal membrane formation, and collagen 1 and 3 and fibrillar collagen is deposited. Now, what are the tools for assessment of fibrosis? Physical examination. Obviously, if you got a patient who's got a history of hepatitis C or B, and he presents to you with upper GI bleed or hematemesis, that might be a clue in the history. Physical examination, there are a lot of markers of chronic liver disease, ascites being one of them, that will lead to a diagnosis on a clinical basis. Liver biopsy, the gold or not so gold standard, is one of the options. Imaging has been dealt with in the previous sessions. Serum markers and liver stiffness measurement, don't think it has been covered properly. So I'll be dealing with serum markers. The role of ultrasound has been already alluded to early on, but I just want to emphasize that liver biopsy cannot stage the fibrosis. It can only detect cirrhosis, and that only in 40% of the patients. So we're talking about normal ultrasound available everywhere. So what about liver biopsy? The liver biopsy is useful. It will tell you about the staging of the fibrosis, the activity of inflammation. It can also give you some idea of the etiology of the underlying liver disease. And in staging fibrosis, various staging systems are used. One of them is the Ishak score, which is 0 to 6, and the common one used is Metaverse score from 0 to 5. F0 to F1 is mild fibrosis, F2 is moderate or significant fibrosis. This is significant fibrosis, which is different from cirrhosis. F3 is severe fibrosis, and F4 is cirrhosis. So staging of fibrosis is important because it predicts progression to cirrhosis, and also it predicts liver-related complications and liver-related mortality. A liver biopsy, obviously, as mentioned, it gives you the opportunity to stage and grade the fibrosis and inflammation and underlying etiology, like you can stain for iron, you can detect autoimmune liver disease or an FLD or NASH. But the disadvantages are that it is invasive, it has got risk of complications, mortality can be 0.01 to 0.1%, and it is limited by sampling errors and inter-observer variability. So we need some liver biomarkers so that we can circumvent all of these shortcomings. The ideal biomarker would be liver specific. It should be inexpensive and easy to perform, independent of metabolic alterations, detect fibrosis regardless of the cause, and it should be sensitive enough to distinguish between fibrosis stages, and it should be reflective of a dynamic process going on in the liver. That means fibrosis progression versus fibrosis regression. Serum markers of fibrosis are largely divided into indirect markers and direct markers. Indirect markers are simple chemistry or hematology tests, and they are elevated due to liver injury or inflammation or a consequence of fibrosis. And they include ALT, AST, gamma GT, cholesterol, bilirubin, platelets, ApoA1, heptoglobin, alpha-2 macroglobulin. And direct markers are markers of extracellular deposition and degradation. Indirect markers or methods are further divided into simple methods and more specialized tests. The simple tests which we know of are the most common one utilized is the APRI and the FIB4 and NAFLD fibrosis score, BARD, FONS, AST-ALT ratio, and there's so many others. These are simple, you can just get them from your ordinary simple laboratory, except a few of them. Parameters, and specialized tests can only be performed in designated labs. They're commercial assays, they use patented equations, and they're expensive, and I don't think they're available in our country. So simple tests, before you go on to evaluate tests, you should know something about the positive predictive value, negative predictive value, sensitivity and specificity. Positive predicted value is used to rule in a disease and negative is to rule out a disease. Sensitivity is when a patient has got the disease, the test should test positive, and specificity is if he doesn't have the disease, the test should test negative. Something basic about ROC curves, area under the receiver operative curve. You should know that if a test is on this diagonal line, that is not a good test. A good test would be somewhere up here, in this area, left upper quadrant. So the commonly used tests which are available are APRI, and the equation is AST divided by upper limit of normal into 100 divided by the platelet count, FONS index, and the FIB4, the formula is given over here. The equations are difficult and cumbersome, so nowadays life is very easy with the advent of the smartphones and the apps. So many apps available for calculation. One of the app is the MDCal. It is used worldwide. It is in 196 countries or 1 million monthly users. And it supports 45 plus specializations. So if you download it, it is available, or you can use it offline. I got stuck somewhere. Can you move the slide? Okay. This is a screenshot of the MD calc on one of my computers, and developed by Analog. You use AST, you fill in this tab, and then the upper limit of normal usually is 40 in most of the labs, and the platelet count is, you put it in here, and you get a result over here. So this is advantageous in that it also gives you when to use a test, what are the pearls and pitfalls, why use it, and it also gives you some interpretation. This is the interpretation written below that. And APRI score greater than 1 had a sensitivity of 76% and specificity of 72% for predicting cirrhosis. And for detection of cirrhosis, a cutoff of 2 was more specific but less sensitive. So a cutoff of 0.5 can rule out significant liver disease, and cutoff of 1.5 can rule in significant liver disease or cirrhosis. FIB4 uses the same parameters except age and platelet, and ALT comes in now. So you see that AST is very important in calculation of these values. Most of the laboratories will omit AST, they'll just report on bilirubin, ALT, and alkaline. So it's best to have a lab with gives you AST value as well. So the negative and positive predictive values have been shown here. Cutoff of 1.45 was highly correlated to fibro test in 92 to 97% of the cases. So the cutoff of 1.45 and 3.25 are used. EP and FIB4 has been used in the WHO guidelines as well. This is the 2016 carried on 2018 guideline, and it says that in resource-limited settings, it is suggested that why not APRI or FIB4 be used for the assessment of hepatic fibrosis rather than other non-invasive tests that require more resources such as elastography or fibro test. And below that, the note is this recommendation was formulated assuming that liver biopsy was not a feasible option. FibroScan, which is more accurate than APRI and FIB4, may be preferable in settings where the equipment is available and the cost of the test is not a barrier to testing. This applies to third world countries in our settings. Same as here, the hepatitis B guidelines for the WHO. It says that APRI is recommended as the preferred non-invasive to assess the presence of cirrhosis. APRI score of more than 2 has been used here or suggested. Other scoring parameter for NAFLD is the NAFLD fibrosis score. Again, you've got various online calculators. This is another different online calculator on Windows. This is also available in MDCal and others. So the various parameters are shown, and it has got a complex equation. The NAFLD fibrosis score and FIB4, they are being used to stratify NAFLD patients for further interventions. I don't know whether you can see clearly. If you've got a FIB4 of less than 1.3 and an NAFLD fibrosis score of less than 1.4, the patient is categorized as low risk. But if it is more than these values, it's categorized as intermediate risk. And these low-risk patients, you don't need to do anything. You just use lifestyle modifications. In intermediate-risk patients, you go for further evaluation, like you do a transient elastography to see what values you get, and you can go for liver biopsy accordingly using this algorithm. For fibrosis assessment in NAFLD, the best test would be the ELF test or the fibrometer with sensitivity and specificity in this range. Now we just talk about a little about specialized tests. The specialized tests, fibro test, for example, the trained in Europe it's fibro test, and in US it's FibroSure. It's been developed by this biopredictive company in France, and it uses like complicated molecules which you don't usually get in your ordinary laboratory, like haptoglobin, alpha-2 microglobulin, and gamma globulin, apolipoprotein A1. So these are the common ones. This is a combination of simple parameters like bilirubin, and these are the more complex tests or chemicals. So it can classify fibrosis into 1 to 3 categories: mild, significant, and intermediate. And it has got a sensitivity of 75 and specificity of 85% to detect F2 or more stages of fibrosis. This has been changed to ACTI test with the addition of ALT, and that makes it more better. These are the area under curve of fibro test, and it compares to the fibrosis stages on Metaware scoring system. If you compare APRI to FibroTest to FibroScan, the best to choose would be FibroScan, and after that FibroTest, and after that, below that is APRI. But if you combine, for example, the FibroTest with FibroScan, you get better results in sensitivities and specificities. So the indirect markers, as you know, they're not actually markers of fibrosis or fibrogenesis. They are indirect consequences. So they are non-invasive, they are cheap. You can use them to detect significant fibrosis. In unevenly distributed fibrosis, for example, in liver biopsy might get you a tissue from a normal area. So that could be misleading. And the disadvantages are that they're not sensitive enough to distinguish between stages, and there's no linear correlation between biopsy. So we go into the direct markers. Direct markers are they measure the quality and quantity of changes, qualitative or qualitative changes in the extracellular matrix. You've got markers of matrix deposition. If you recall the previous diagram of fibrosis pathogenesis, procollagen type 1 carboxy terminal peptide, procollagen type 3 amino terminal peptide, TIMP, which is tissue inhibitor of metalloproteinases, and transforming growth factor beta. Markers of matrix removal would be procollagen type 4, C-peptide, N-peptide, matrix metalloproteinases, others like hyaluronic acid. So these are used in combination with simple markers to you get various like tests like fibrostat, fibrometer, Apasl, ELF test, and the Shasta test. They use mainly one of or more components from these direct markers, and they're more sensitive and specific.